Hi, Monnie.
Hi, Neghae. How are you?
I'm okay. How are you?
I'm well, thank you.
We are here for the Nephro-Logic podcast.
We are. We're kicking this off, and Neghae, why don't you just tell us who do we want to reach with this particular podcast as we start it out?
Well, I think anybody interested in dialysis access, right? Basic introduction. My name's Neghae Mawla. I'm an interventional nephrologist in Dallas, Texas. I work out of a hospital setting, and I run a dialysis access program. So I've got some community surgeons that operate with me, and really all we do is focus on dialysis access needs.
And I am Monnie Wasse. I'm an interventional nephrologist also, but I work in an academic medical center setting and have a history of having worked at an outpatient ambulatory freestanding center. And now I've transitioned to doing my procedures in the outpatient area of our hospital. So it's a very different structure in terms of efficiency and some of the practice settings that many of our colleagues have that are in private practice. We will be able to get into that a little bit later in some of the series of our podcasts.
Correct. And you and I both have experience in an outpatient ASC and how that differs from a hospital setting. So, and that's newer for me. So I'm learning the differences there. But the idea here, we've talked about doing this for a long time and is really to reach, I think, general nephrologists who don't have that much expertise with vascular access care in general and things they can learn along the way. Surgeons who are interested in access, interventional radiologists that are taking care of dialysis patients, and of course, dialysis providers themselves, the nurses, PCTs. I think anybody who's got an interest in helping manage dialysis patients and their vascular access, hopefully we will have some things to discuss along the way with them.
Yeah, I agree. And this is the first dedicated dialysis vascular access podcast that I'm aware of. Throughout the series, I think we're going to try and cover some topics that are really pertinent to people that do a lot of this type of care.
I agree. Okay. Most, nephrologists understand dialysis. Obviously, nurses, PCTs understand dialysis, but a lot of surgeons and radiologists may not understand dialysis. So how about we start with a dialysis 101? So Monnie, in 1 minute, can you break down what is a dialysis access machine circuit? How does that work?
Yes. So for those unfamiliar or who haven't traveled to a dialysis center or haven't popped over to your inpatient center, the principles are relatively simple. There's the inflow and the outflow. So the arterial needle pulls the blood from the dialysis, either catheter or the fistula or the graft, spins it into the machine. The blood gets cleaned there, and then it returns it through the venous needle. So the venous needle return is a positive pressure. The arterial needle, which is a pulling to the machine, is a negative pressure. And so those are the two key things that you have to keep in mind. So, what informs us around practice when we get a referral from a patient or from the dialysis unit is, are the pressures abnormal or are they normal? And that can help indicate whether or not there's a problem with inflow versus outflow.
So I always like to think of the dialysis machine as another organ, as an end organ. So the line to the machine is your artery, right? Your arterial line. So if you were thinking vessels, and the one returning from the machine back to the heart is your venous line. So if you're ever confused which way is which, then simple way to go. You brought up arterial pressures, venous pressures. These are often complaints that I see or hear about from the dialysis clinic. Can you explain to me what that means?
Yeah. So when the dialysis unit has a standard dialysis prescription, they set a pump speed. And the pump speed is anywhere in America, it's usually anywhere from between 350 to 400. And that allows the patient to be able to dialyze in a relatively timely fashion, 3.5 to 4 hours-ish, for them to get a sufficiently clean bloodstream. So the arterial pressures are set at a level in which that pump speed is gauged, turned on, and then anything outside of a standard parameter, quick and dirty, is around minus 200. Anything more minus than 200 is our abnormal on an arterial side, and anything generally more positive or a push pressure that's more positive than 200 on the venous side is generally considered to be abnormal. And we look at the trends in these over time and look to see whether or not they may be reflective of a problem within the dialysis circuit. And that problem can occur in a lot of different locations. It doesn't necessarily have to be within the dialysis access per se, but that's typically the place where people go looking first because it's the most obvious spot.
So to me, arterial pressure alarms means inflow.
Yes.
Because the dialysis centers are very good about specifying to me whether it's an arterial alarm versus a venous alarm. They'll write that down for me, usually in the referral. So right there, that's a clue to me that I need to focus on the inflow side of it versus the outflow side of it.
Yeah, I think that's really important too, because you want to know what your target lesion is. I mean, some of these accesses have areas that might appear to have, 30, 40% narrowing, but they're not necessarily the one that is restricting flow. So you want to have some clues before you start
Before I
your.
start, right?
Yep.
And it might be something as simple as if I hear it's an arterial alarm, then I know I'm going to set up for retrograde access directed towards the inflow. I'll have a compy and a wire on the table so I can get right up into the artery to take a good look at those kinds of things.
Yeah, and we always take a quick C with ultrasound first just to confirm which direction we want to go. It's not always the case that they give you that information. Sometimes you have to call the dialysis unit and get placed on hold for a little bit before you're actually able to get a hold of someone and get it. But it's definitely worth doing it because it can be very informative and make for a much more efficient procedure.
Absolutely. Either myself or having one of my staff call and get a quick update. What's the real issue going on? Why this guy's here will change the game completely.
Yep. Those are the two things that I think are important. And then obviously some symptoms that patients might come in with, which are anywhere along the lines of prolonged bleeding versus difficult cannulation. Those are all things that give you clues as to whether there might be a problem with inflow or outflow.
Do you have a kind of a guideline for the prolonged bleeding?
Yeah, I consider it, especially if the patient is on a blood thinner, which a lot of them are. They're on some baby aspirin or they're on Eliquis. I typically have a gauge of anywhere beyond 20 to 30 minutes, and it has to typically be more than one or two events. Typically, there's a trend. So if it's just a one-time thing where somebody may have gotten heparin late in their circuit and they end up coming to me for an evaluation, I find it rare. Rarely do I actually find a problem in those patients, but it's once the issue has occurred several times that I think it's worth investigating.
And I agree. Most of the patients that come for prolonged bleeding have, they're hitting the 45-minute mark, sometimes 1 hour plus. And you really don't need to wait that long, I think, to really get in there and investigate either. I always tell them to go back to pay attention after the intervention. Hey, see what next treatment looks like. Check after 5 minutes, 10 minutes, establish a new baseline. The rule I tell my patients, because this is more for the patients, the staff are taking so many people off. They're not paying attention to who's holding pressure longer and who's clamping longer. And we can even get into the clamps. But what I tell my patients is double your baseline for 2 weeks, is kind of the rule of thumb. Because you're right. Sometimes something happens and you just bleed a little bit late, or hey, let's try a different spot and you bleed because of that. Or so double your baseline for 2 weeks is really what I say. That at that point you need to say, hey, let's get this looked at, and
Yeah.
either come into the clinic, do an ultrasound, or come in for a procedure and go from there.
Yeah, I think it's also worth considering. I mean, in patients that have this come up where they may not even have a lesion that you find, but they've been having prolonged bleeding, just doing a reassessment and check in with the nephrologist about their blood thinners. I had a patient 2 days or 3 days ago that was on full strength aspirin, Eliquis, and Plavix. And that required some questioning as to why this individual was on so many blood thinners. And it turns out that it was a little bit of a Hail Mary from the surgeon because they were trying to ensure that the patient definitely didn't clot. Well, that wasn't the problem. The patient was really struggling to get out of the dialysis unit after having 2 large bore needles put in them and was holding pressure for 50 minutes. So there's an opposite end of that bell-shaped curve where people can be bleeding because they're just over thinned.
So you bring up needles. So let's talk about needles for dialysis. People will talk about different sizes, different gauges, different lengths. There is the 17 gauge needle, which is kind of the introductory needle, which is typically what I think we start with new access cannulation, at least in fistulas. For grafts, I don't typically insist on 17s, but for fistulas, convention kind of says start at 17, start at low flows, and then you work your way up to 16 gauge and then 15 gauge. In patients that can't get enough clearance, I have put a few patients on 14 gauge needles just to run the pump speed higher because you just can't clear them, in the 4.5 hours window.
Yeah, I don't do that. I have a problem with 14 gauge needles. I think it's worth cranking up the dialysate rate to 800 if you're struggling to meet dialysis clearance and just adding time. 14 gauges are big, and having one of my previous institutions that I worked in, there were a lot of people in the community that used them, and they tended to really promote stenosis within the access. So I draw the line at a 14. Different
Okay.
practice pattern, yeah.
So one of the variations that I learned a couple of years ago was actually there were shorter needles. So the standard needle is your 1 inch. There is a 1.5 inch, 1.25 inch, a longer needle, but there's also a shorter needle, a 3/5 inch.
There's a 5/8 inch. Yeah. And
5/8.
and I use that quite a bit with really superficial access. It reduces resistance, and a lot of times you can get a higher blood flow out
Yeah.
of it. So I like those a lot.
And one of the things I learned recently is that you can run 400 pump speed with a 16 gauge short needle.
Needle. That's right.
And so you don't even have to go to a 15. Okay. So we've talked needles. We've talked about inflow, outflow pressures. Some of the clinics do flow studies every month. The Fresenius clinics have their twister lines that they do. The IRC clinics use the vascular system here in Dallas. And so they all have a routine kind of surveillance program in play. And they will often say, hey, this is trending down. Is that always of significance?
I don't find it particularly useful in fistulas, particularly the Fresenius twister that they use. I think trend analysis is always helpful, but it's not always indicative of there being a true stenosis that's within the circuit. And I think that it can be more helpful in AV grafts, again, because there's a trend analysis from month to month that can be useful in directing you to a stenosis. But I couple that with a physical exam and then with patient symptoms. And then again with venous and arterial pressures. It's not the only indicator that I like to use because I think there's enough times where it's actually not specific enough.
I agree. In a fistula, what I've noticed is that because of collateralized outflow vessels and channels, your flow numbers may not change. And so a stenosis in the primary outflow can change, but because of collateralized, the monthly number stays the same. It doesn't really drop. And so you start looking at other kind of markers. I agree. And I think that's the important thing is that we really have to take it home in the setting of multiple clues that we get, as opposed to, just one clue. Usually my referral sheet will have a list of indications, problems for the dialysis center to kind of click off. And usually when they're checking off more than one, then we say, yeah, there's something going on. And you talk to the patient and you can figure out, yeah, there's really something going on. Versus the ones that have a very specific one reason only, a lot of times those studies end up becoming normal to me.
Yeah, I agree. I have the same type of a form that we use for the dialysis units. And, honestly, it's really important to understand what the circuit is because I don't quite know how I would be as capable an interventionalist if I didn't understand what high venous pressures meant, what very negative arterial pressures meant, and what these signs and symptoms were indicative of. So it's worth learning if you're doing a lot of these types of cases because it just improves your efficiency and doesn't waste as much time and really goes about treating the true patient problem that they've come to see you for, as opposed to you fishing around and wondering which one of these multifocal, non-really significant lesions do I actually treat, which you see sometimes happening with interventionalists that don't understand dialysis.
What about adequacies, URR, KT over V, clearances that they say, oh, my labs are worse when the patient comes in? What's happening? Oh, they told me the labs aren't as good as they were last month.
Yeah,
How reliable is that for you?
I think that that's reasonable. What it means is that you have to get more information because sometimes the KT over V gives us an idea of how clean the blood is getting. Basically, we want it to be greater than 1.2. Sometimes that can be influenced by the patient not showing up for the dialysis sessions, cutting their dialysis sessions short. So it really has nothing sometimes to do with the dialysis vascular access. So there are some questions that you have to ask around compliance and whether the patient is actually continuing to meet their dialysis prescription by showing up when they're supposed to and staying for the length of their dialysis. I think the URR is one that you can't really get away from. I think that tends to be very helpful, the urea reduction ratio, because it gives you an idea of recirculation. Typically when that's off, then there truly is a significant stenosis that's within the circuit, typically in the cannulation segment someplace, that warrants treatment. What do you think?
But again, that assumes a full treatment, right?
It does.
Most nephrologists, or most of the clinics, I should say, are the first thing they'll look at when they see an abnormal clearance, either KT review or URR. It's what was the treatment time? And did they get the full prescribed treatment? Because if they did not, do it again. And most of them actually have a habit of repeating it, even if they got a full treatment time. Let's just make sure that the value is real. So when they come to me for that, usually it's been repeated once already, and the repeat value is still off. Even with the flow studies, they usually will repeat the flow studies and say, yeah, we have 2 flow studies this month that were consistent and off. So to the nephrologist, absolutely. If you get a abnormal KT/V or URR, make sure that that was a complete treatment. What else are we looking at from the dialysis clinic side that would prompt a referral to an interventionalist?
So one of the big ones that we all have struggled with, because it can get to be very obvious to us, but not, I guess, so obvious to the dialysis unit, is the skin integrity over the AV access. That is something that even if your dialysis access is functioning fine, if the skin integrity is starting to wear down, if you're starting to get, scabs or areas that simply aren't healing properly, or if there starts to develop aneurysms or pseudoaneurysms that reduce the amount of space that you have for your needles to go into, those are times with which to refer either the patient to your surgical evaluation or for an interventionalist if it's coupled with signs and symptoms that might suggest narrowing in the axis itself. So those would be things to really pay attention to. And I know we're at a lot of these dialysis access meetings together, Neghae, and we go through this because we see patients where you're looking at the access and you're like, somebody's been looking at this thing for the last, 3 months. It didn't just turn this way overnight. This ulcer didn't just show up, or this non-healing scab didn't show up, or this significant hypopigmentation. And I think that that's really more an issue around education of the dialysis personnel than anything else. They oftentimes don't know what is problematic and what isn't. So doing more to get out in the units and really teach people is very helpful.
So how would you, as far as the thinning skin, what's your take-home message to them for that? What's a quick and dirty lesson that they can walk away today, say, okay, this is how I assess skin integrity?
So one is visibility. So if the patient starts to lose pigment, and a lot of our patients are patients that have pigment. So if they start to lose pigment and have a hypopigmented lesion that starts to get thin, I try and teach the pinch test, which is when you actually go over that area with your fingers. And if you can actually lift a little bit of that skin off of the axis itself, that typically means that there are at least 2 layers that are of skin that have some skin integrity. But if you can't move it and it's fixed to the axis, then that typically means that you've got one tiny little layer of skin that's separating that blood from the free air, which is a problem. So that's one of the things I think that is instructive. But anytime that there's a question, what I do at the units I go to is I say, take a picture of it, send me the picture, and let me take a look at it myself.
Right. And this is one of the things that I think as an interventionalist or an access care provider, you can be a surgeon or an interventional radiology nephrology, is being able to have clear lines of communication between the dialysis centers and ourselves. Because I agree, I get pictures all the time. Usually somebody at the clinic, whether it's a vascular access specialist or the facility administrator, has my cell phone, and they are welcome to text me and shoot me a picture saying, hey, can you take a look at this real quick? What do I need to do? And how urgently do we need to act?
It's also a great way to help to direct care that might be urgent, as you mentioned. So if somebody's got an ulcer that looks like it's pulsatile and ready to blow, they don't need to see me. They need to see my surgical colleague. And it's very easy for me to convey with no words the necessity of getting that person in to a surgeon. And then I can send the same picture to the surgeon and just say, hey, this patient's going to be coming to you with let's see if we can get a bed for them. And they need some immediate attention.
And again, that opens up the channels between myself and my surgeons, because if the clinic calls the surgeon's office and says, oh, we've got an aneurysm, can I get them in? They're not able to always relay the urgency. And so sometimes they say, oh yeah, we got an appointment in 3 weeks.
Here's the picture. Yeah.
And when they see that, they understand, and they say, okay,
they understand.
They understand.
So I always ask for that.
Okay, good. I think just the few things we've talked about today has started planting seeds for things that we can go into in much more detail and in depth, including, for example, aneurysm evaluation assessment, skin integrity, those kinds of things. Let's wrap up today.
Okay.
Give me a take-home message for any general nephrologists that might be watching or listening right now.
So general nephrologists, when you're referring patients, we really heavily rely on the information that's provided by the dialysis unit. It lets us treat your patients and target the lesion that is going to make a big difference with regard to their dialysis clearance. So provision of that information is really helpful.
Okay. For dialysis nurses and dialysis techs that might be listening and watching,
we are here to support you. We know that you have a lot of work and you're very busy at the dialysis units, and we want to be your partner. So if there's an opportunity for us to do that and get our cell phone numbers and be able to send us pictures about things that might be questionable, we are here for you and want to educate and serve your patient population alongside you.
Yeah. And I think most physicians that are interested in dialysis access know how important the PCTs and nurses at the clinics are in being able to provide good care for these patients. And that's what we want. And we do rely heavily on the information you guys provide and being able to talk to you or to somebody there. To surgeons, Monnie, what do you want to say to the surgeons that are joining us today?
What I want to say is we are all in this together and we want to help you, but we also want to partner with you. We work really closely with our surgical partners where I am, and there's a very symbiotic relationship that we have. And that, in my view, is the relationship that best serves the patient, which is why we're all here. Establish a rapport with your interventionalist because they can really help you and preserve the patient's access for the long term, ideally.
Right.
So
Yeah, symbiotic is the right word because I will send them surgical interventions, but they will also send me, hey, this patient came to my office. He just needs a quick angioplasty. Can you get it done for me? And it's for me, that's easy to do versus for them when they're covering multiple specialties and multiple organs and different parts of the body, a quick angioplasty for a dialysis patient sometimes is a lot harder to work in.
yeah, absolutely. Okay.
And patients, if there's any patients listening, Monnie, what would you say?
For patients, this whole team can be very challenging because it's very fragmented care, vascular access is. But if you can get one champion, if that's your PCT at the dialysis unit, if that's your general nephrologist, or if that's the interventionalist that you tend to see when you have a problem, ensure that you keep a relationship with that person because they really are there to help you and to help you work through this and to really preserve your access for as long as possible with as few interventions as possible. So I would say get educated as much as you possibly can, ask questions, be skeptical. And if you're finding that you're going to the same group or people for the exact same things on a regular basis, just know that that's typically not normal and you should be asking why. I think that that's a key thing for patients because so many of them get shuttled back and forth to dialysis access centers with regularity and they may not always need it.
And I think the biggest champion for the patient is yourself. Like you said, get educated, start to understand. If you're a patient and you're listening, obviously you're interested and but I think you become the champion for not only yourself, but you can do it therefore for all of the other patients in that clinic that you're sitting with.
Right.
Fantastic, Monnie. I think there's a lot to come here and I'm really looking forward to sitting down with you and some guest hosts we can bring on and go through. I think we can get into a lot of practical things that you and I talk about and we exchange at meetings, but not everybody's able to attend all the meetings throughout the year. And so for those that are not able to, I think hopefully we can bring some of those topics here and get a lot of interest.
I agree. Okay. Looking forward to the next set.
Great. Until next time, Monnie. Thank you.
Bye.
Bye.